Hello, everyone. Welcome to today's Global Grand Rounds. My name is Aisha Siad, and I will be your host for today. Before we start, I'd like to go over a few things. This presentation will be recorded and uploaded to our YouTube channel. If you watch our videos on YouTube, remember that there's an option of playback speed to adjust the speed of the presentation. On Zoom, you may turn on the closed captioning during the presentation to allow for subtitles. And with that, I'd like to hand it off to our medical director, Dr. Pecchia.
Thank you, Aisha. I appreciate your work and the team at Global Offsite Care for hosting Global Grand Rounds. And I'm Dr. Gregory Pecchia, Medical Director of Global Offsite Care and a colleague of Dr. Anita Nelson at the Western University of Health Sciences in Pomona, California. We're welcoming Dr. Nelson again. She's Professor Emeritus. Previous to her current position, she was at UCLA for many years and is also professor of obstetrics and gynecology at Western U. She has been, for the past number of decades, been medical director of the research division for Essential Access Health. That group is one of the founding members of the NIH, National Institutes of Health Contraceptive Network, and has conducted phase 2 through phase 4 trials for a wide array of female and male contraceptive methods. Altogether, she's been responsible for close to $68 million of research grants and published over 270 articles in professional journals, 80 chapters, and over 175 abstracts. She's given over 3,200 CME lectures and is particularly passionate about teaching and advocating for reproductive justice. So with that, I welcome you once again. Dr. Nelson, the floor is yours.
Thank you so very much, and it's delightful to be with all of you, although it will be, I understand, delayed. But however it is that we do get to communicate, I'm looking forward to chatting with you all around the world and want to applaud for the work that you have. And if we just timed this right, a couple of days earlier, it would have been International Women's Day. But certainly this topic can be any day of the year. We need to talk about bleeding and menstrual disorders, and particularly heavy menstrual bleeding, how this very adversely affects the well-being, productivity, health, of women, and of course through them their families. So we're going to be talking about that today. I do have potential conflicts of interest, as you said. I do work with a lot of pharmaceutical companies developing new methods of birth control and other issues around women's care. Now, there is obviously going to be an overlap between the work I've done and with contraception and the topic that we have today, but I'm hoping there won't be any bias. I welcome any comments. If you do perceive bias, it's unintentional but correctable, so do let me know if you see something. I want today for us to really embrace in our daily practices the definitions about what's normal and abnormal in bleeding for women, and to really see if we can't be standardizing the use of the palm coin classification system for menstrual abnormalities. Now, I know many of you are international and in areas where FIGO is well recognized, so you may be ahead of the curve. In the United States, it has been endorsed by all of our organizations, but not really implemented yet, and that's really unfortunate. So for those of you who already know about this, I really thank you for your good work, and I appreciate your patience as I get a little bit passionate to try to persuade those who need to learn more about it. I want to talk a little bit about the evolution of menstruation in human and how the defects that could disrupt the control of bleeding itself. And of course, what you and I are all about today is really the workup of a woman who has acute heavy menstrual bleeding or chronic heavy menstrual bleeding, or worse yet, both, right? And see if we can't personalize it to her own risk factors and how she presents. So it's going to be a bread and butter sort of a presentation, and hopefully applicable in the situation where you work. This is, of course, the definitions for menstrual bleeding, the terminology that the Federation of International Obstetricians and Gynecologists has put out, and it's been available. Gosh, I remember going to South Africa for a planning meeting in a FIGO, and that was 3 cycles ago. So this has been more than a decade that this has been endorsed by organizations. And I would really ask you to think about every time you're meeting with a woman and you're doing something clinical with her. I know you ask about last menstrual period because you want to know, is this woman pregnant or not pregnant, right? Those 2 categories really do influence many of the things that you can or cannot do for her and give you insight into maybe some of the causes of the problem she's presenting with. But beyond that, there are really 4 pieces of information we need to capture about a woman's menstrual pattern. And whether you do it on a routine basis or you do it initially and then just ask if there's any deviation, but most certainly when she comes in with menstrual abnormalities, you really want to record the frequency of her bleeding, how long she bleeds, how much blood she loses, and how regular her cycles are. So if we're going to be using terms like this, and these are the terms we want to embrace, we want to get rid of those really imprecise conglomeration of Latin and Greek words that nobody could spell, right? We want to use these terms as we're talking to each other and recording the patient's history. So frequency, what is normal today is that from the first day of a woman's period to the first day of the next period, it should be 24 to 38 days. Now, those of you in the United States may recognize that the FDA still is doing that 28 days plus or minus 7. So they do 21 to 35. I'm not so fussing with the 21, 22, 23. I'm not going back and telling women that they're abnormal, but I do recognize that we can go further, particularly in the face of increasing BMIs. We're seeing that women are kind of shifting the frequency of their bleeding patterns, and up to 38 days is normal. So what do we call if a woman's periods are less frequent, right? If she bleeds every 45 days. Well, that's not anything oligomenorrhea, because that meant either infrequent or light bleeding. We use the English word infrequent. And if her cycles are closer together, then we call them frequent bleeding. The duration of bleeding we have to pay attention to here. Normal overall for a population is up to 8 days of bleeding. And anything longer than that is prolonged. But what if a woman has established a pattern that her whole life, her whole gynecologic adulthood, she's bled for 4 days, and now she's bleeding for 8 days? That's a change. It still may be normal overall, but for her it's a change, and it should prompt us to look for why it is, the cause, the underlying cause. Now, how much she bleeds, you and I'm sure, have encountered all kinds of patterns, and what you and I are going to talk about mostly today is heavy bleeding. And it has an objective definition, more than 80 mLs. But how are you going to know, really, that she is losing a lot of blood? There are some symptoms you can ask about. Does she have to change her protection more than every 2 hours? Are there large clots? Does she have to use a towel when she gets up in the morning so she doesn't soil the bed and the way to the restroom? Those are really egregious. But the first line of definition here is what the woman characterizes her bleeding as. Now, I know that's inaccurate, but in particular, it is probably, if a woman says her period is heavy, by definition, it is heavy. Now we'll go back and get some more information about that. Is it objectively heavy? We will respond to her characterization of heavy and do something to alleviate that concern. But are we going to do $1 million workup? I think we've all been there where the patient goes, "Oh, my periods are so heavy," and you do a hemoglobin and it's 16, and you're pretty glad that she doesn't have any higher hemoglobin, right? But so we would make her feel better by treating that, but we might not have to do a large workup on it. Regularity, if you have 6 months of information then what's the difference between the length of the longest cycle and the shortest cycle? If it's 10 days or greater, then it is irregular. So those are technical terms, but I think we really want to characterize for a woman her bleeding pattern, so the next person picking up her chart will know what we're talking about. Other terminology that is carried over from prior use: intermenstrual bleeding. She shouldn't have any of that. Is it random or is it predictable? And we want to say if it's cyclic or predictable when it occurs in her cycle. Unscheduled bleeding is actually the terminology we're supposed to use. Scheduled bleeding and unscheduled bleeding is how we characterize bleeding when a woman is using hormonal methods of birth control. Because you and I know she's not having menstruation, she's not having her period, or whatever the usual term is. It's scheduled bleeding versus unscheduled bleeding. She ought not to have any of it. But if she is having bleeding when she's not on the placebos, then it's called unscheduled bleeding. Other things that we've brought over is postmenopausal bleeding. That's easy enough. Postcoital bleeding, and that's usually something people forget to ask about. Things we've thrown into the trash barrel are all those interesting terms: menorrhagia, menometrorrhagia, metrorrhagia, polymenorrhea, and very important, dysfunctional uterine bleeding. We have tried to eliminate that term since I've been in medicine, right? And that's a long time. But it is like a little whack-a-man. You tell people that's a meaningless term. If you mean anovulatory bleeding, call it that. But it's the garbage bag. When we don't know what it is, it's dysfunctional. And you pop it down and it pops up over here. So as a group, shall we hold hands and say, we will not use that term again because it is not at all helpful. So amenorrhea, whether it's the first period she hasn't had or she's developed no bleeding for the last 6 months, postmenopausal, post-traumatic, and we have those terminologies. So FIGO has firmly established that chronic non-gestational abnormal uterine bleeding in reproductive years, this is the definition, and they want us to be able to characterize those things that you and I talked about, and they're saying that these changes, these abnormalities have been present for the majority of the last 6 months. So then we can call it chronic abnormal uterine bleeding. Where's the cutoff for acute? Well, if she has an episode of heavy bleeding that, in your opinion, is sufficient to require immediate intervention to minimize or prevent further blood loss, then she's got the diagnosis. So I think those are operationally very easy for us to embrace and to agree upon. I've told you already that the theme, and it actually originated in Britain with the National Institute of Health and Clinical Excellence, NICE, saying that heavy menstrual bleeding, excessive menstrual blood loss, which interferes with a woman's physical, social, emotional, and or maternal quality of life, that's what it is. And if she says it's heavy, it's heavy. So clearly, how frequent is this? And I know if you in practice, you know that it's very, very frequent. It's a very common gynecologic problem. Usually at least 10% of healthy women, and they are overrepresented in outpatient clinic visits, right? You can see 20%, 1 of every 5 reproductive visits is going to be about heavy bleeding. And if a woman has self-reported excessive bleeding, she's much more likely to have impacts elsewhere, much more likely to use health services, much less likely to be working. And in an analysis done in the United States more than 15 years ago, that lost work, that lost productivity cost her almost $1,700 every year. So where did we get our definitions for what's normal? And I just love this. And you have to put, that's why it's good to know where the numbers come from. There was a family practitioner in Sweden who collected the products that his patients used in the 1960s. And he found that no one who lost less than 60 mLs of blood developed iron deficiency. Right? But remember, that was based on the typical Swedish diet of the 1960s and the activities of those women. But of the healthy women, the 90th percentile was at 76 mLs of blood loss. So that's where we rounded it up to 80. It's an easy number. We've seen more recently, though, that people can have ferritin. Now, if you're following ferritin levels, that's a little different than measuring serum iron. And we can see that we begin to see that if her ferritin is greater, less than 120, then she certainly is much more likely to have excessive blood. Or you could do it the other way. If she loses more than 120 mLs, she's much more likely to have ferritin abnormalities. How do we measure blood loss? We realize this is a problem. When I do the clinical trials, literally we have the women use standardized products, refrigerate them, send them overseas, have them elute the hemoglobin, measure what the blood volume is in that compared to what she's got in her hemoglobin. It's not reproducible in practice. It's great for research. It's very accurate. Can you do pad counts? How many pads do you use? You got it, and we're going to see the difference in the pads and the other products. And then we have some very fastidious women, and we have some really pioneer women, and women who don't have a lot of resources, so they try to get every little, squeeze they can and maximize the use of each product. There is pictorial blood loss assessment charts, that PBAC that you see. That's good for sort of clinical research. So the PBAC score of 100 is our cutoff. It's the 80 mLs. And I thought this just came out. Somebody actually tried to see how much volume various products can have. And in the US, they've been touting underwear, that these are fantastic products, but they hold very little volume altogether. But there are menstrual cups that are very helpful. And I'm hoping that if you're in areas where women do have challenges and you're evolving into getting sanitary protection for products for women, getting them adopted, that you kind of skip over what we've gotten stuck in the US, and that's disposable. So using menstrual discs or cups or washable products certainly is so much better for the environment and is certainly much more cost effective for the women. The blood loss tends to vary by age, and it's very interesting. The highest amount of blood losses that we see in healthy women are actually during ovulatory cycles, in that very last cycle that she's going to have before she enters into menopause. And part of that is it takes so much estrogen, right? So much FSH and so much estrogen to flip to ovulation in those, when they've got sort of down to the last crummy little eggs, that she builds up a lot of endometrium. And it may be quite normal to have a very heavy or prolonged period in that last transition. But that's exactly the time that you're worried about her having hyperplasia. And you might be doing a biopsy but this is a perfectly healthy. So you might want to put her needs in context. Is this a persistent increasing blood loss pattern over time, or is this a one-off? And if it's a one-off, you're going to do something to stop the bleeding, and you're going to keep her from having it heavier. And if she does it again, you may have to biopsy her. This is my favorite. This is real life. This is that Swedish doctor, family practitioner, who actually looked and measured. Remember, we talked about how much blood loss women had had. And remember, this is blood. This isn't menstrual flow. Menstrual flow is only half blood. So the volume that women are losing is much greater than what we actually have in terms of mLs of blood loss. But I hear this is kind of cute. The women who actually had objectively measured losses of 20 to 40 mLs every month, which you and I would characterize as the light to moderate. How did they see it? Well, we had about 10% of women saying, that was pretty light. Most women were pretty accurate and moderate, but look at this. In the women who are losing maybe only 20 mLs of blood, we have 30%. It's so heavy. You want to respond to that. Maybe it is that there are 2 hours every month where she's just losing so much that she's immobilized. She can't go out of the house. It may be a short, acute episode there. And of course, she's going to call that heavy loss. The total loss may not be excessive, but there is that moment when it is heavy. But the one woman who really worries me, let's go way over to the right here. Can you see the women who we know have excessive blood loss? We still have some of those women, maybe 4% of them. That's nothing, right? That's light. And more importantly, you'd miss the 50% of women who would characterize their loss as moderate. Only half of women who have objectively measured heavy, excessive, unhealthy blood losses will tell you that they have that. They recognize it. So it's up to us to do those follow-up questions. She may characterize, my bleeding's moderate. Well, tell me, you already know how many days she's bleeding because you asked about that. But, do you ever have a time when you have to change the pad more than every 2 hours? Or do you ever pass clots, right? Get some sense from her history, whether maybe she's minimizing the blood loss she has. I remember once I was asking a patient, how many days, and she said she bled for 11 days every month. And I said, oh my goodness. And she reached over and she patted me on my knee and she said, that's okay, Dr. Nelson. Every woman in my family bleeds for a long time. And that's exactly the paradigm, isn't it? How is a woman supposed to know what's normal? She's surrounded by people who have the same pedigree she does. And so I said, I need to see them all. None of that is healthy. We need to talk about it. So, and you're talking to young women, when you're talking to women about their menses, do set what normal is so they can be part of the team that helps us define when they need help. I think it's very important for us to realize the role of the hemostatic system in controlling blood loss. Many of us think if we sprinkle estrogen, treat her with estrogen, it'll proliferate the endometrium and it'll stop her blood loss. That's not how it works. Women slough the endometrium in the first 24 hours or so, but they keep on bleeding because they haven't clamped down and formed clots in the spiral arteries that are serving that area. It's absolutely fascinating that you can see proliferation of the sloughed area right next door to a bleeding vessel. So everything that you learned about how blood loss stops anywhere else in the body is going on inside the uterus. So she's got to form that platelet clot. Right away, if she's got low platelets, it's not going to work, right? She's got to stabilize the fibrin and move forward to actually creating the stable clot that allows for reepithelialization over that area too. But realize it's going on early in the cycle. All right, well, let's move to something that's really scary, and that's excessive acute bleeding. And it can present as a very serious medical emergency. We know acute blood loss is not generally well tolerated. In obstetrics that a patient comes in with a hemoglobin of 11 and drops it down to 8. She can barely get out of bed the next morning, right? She's dizzy, she's weak, she's hypotensive, tachycardic. But certainly the etiologies for acute excessive bleeding, and I'm not talking trauma here, but once you rule out things that like pregnancy-related bleeding or an aborting fibroid or an actively bleeding polyp, or she has trauma, or she has a cancer or she's anticoagulated, once you get those out of the order, it's very nice to realize that hormonal therapies that we use every day can certainly arrest or definitely slow acute bleeding, excessive bleeding. So we have tools in our hand to be able to control the bleeding, but obviously you're going to want to rule out those very quickly. So right away, rule out pregnancy, do the workup, but as you're doing the workup, stop the bleeding now, right? And as you're stopping the bleeding, you want to know, what's the initial therapy I need to do? What's the transitional therapy I'm going to do in the next couple of days? And then follow up, give her a month off of bleeding if you can to build her hemoglobin back up, and for you to get back some of the test results, right, that from as you were doing the workup, right, to find out exactly what was the cause. So what have we used traditionally? Traditionally, we did intravenous estrogen. Now, many of us in many sites around the world, there wasn't IV access, but where there was, this became almost standard of care. And for an inpatient, and that they switched, they added progestin once the estrogen stopped it. I'm going to show you how very wimpy those data are that gave us that as the idea. And again, got back to that Disney comic idea that you were trying to proliferate the endometrium. We switched over to high-dose oral contraceptives as first-line therapy to deliver high amounts of estrogen. And where we've gone to more recently now for outpatient therapy in particular is high dose oral progestin. And certainly this is the preferred approach. And I don't think that folks have really embraced how much safer this is and how incredibly effective it is. Now, can you add high dose NSAIDs to help with the prostaglandin imbalance? Yes, absolutely. Now, if she's hemodynamically unstable or the treatment fails, then of course you can move to surgical. You can do dilatation and curettage. You can do uterine artery embolization. And very importantly today, what is really good, if she comes into an office setting or a clinic setting and she obviously needs inpatient therapy, these little balloons that we can place inside the uterine cavity, inflate and transport her when you've actually tamponaded the bleeding. Now, that's not a cure, right? But it will give her an ability to be transferred very safely where she can get the transfusion she needs and all the others. In some situations, we have to resort to radiation therapy and, of course, in the extreme, to use hysterectomy to stop bleeding. I told you I was going to show you how the original work that was done, and this is the only work that's been published on intravenous estrogen. How many subjects were there? There were 17 patients who received IV conjugated equine estrogen and 17 received placebo. At 3 hours, the women on placebo got normal saline were doing better. At 5 hours, they needed the ER beds and they kicked the women out, and at that point in time, the estrogen was working better. And believe it or not, that's the only prospective double-blinded study in the literature showing the efficacy of estrogen. Now, we know the risks of estrogen, and we'll come back to that in a bit. Using very high doses of estrogen, we use combined birth control pills, and you know today we would never do that, but 18 patients there. And where we have the two-digit numbers that are really kind of embarrassing there is the studies with MPA, right? And I'm going to point you to the best study of all, and that's the fifth one, and how it actually has been utilized and published. So the progestin only that we're talking about today is medroxyprogesterone acetate, 20 milligrams. Now, it doesn't come in 20, it comes in 10, so you got to give 2 tablets 3 times a day orally for 7 days, and then once a day for another 21 days. And between Dr. Malcolm Monroe and Askew, we've got really good studies. Now, today, what's in the textbooks are going to be this combined birth control pill, any 35 microgram pill. You're going to give it 3 times a day for 1 day, and then 1 tab a day for 21 days. But here's the big Monroe study that we want to have. And I mentioned it is 20 milligrams 3 times a day for 7 days, then once daily for 21. And they did it double-blinded, randomized, all those good things against what was the standard at the time, which was birth control pills with estrogen, that they gave them high dose 3 times a day, and then once a day for 21 days. And the MPA worked beautifully. And days to cessation was very rapid. Complete cessation was not achieved until 3 days, but patient satisfaction was very high. Nobody discontinued the study. Can we use other therapies to help aid in it? And the answer is yes, particularly if you're going to give her high-dose hormonal therapy with estrogen. If she's had difficulty with birth control pills in the past, yes, antiemetics might be very helpful. You can, as we said, add the NSAIDs. If she's anemic, you're going to give her iron. And many women today, we don't give them menstrual calendars. They've already come to us with their apps in place. And bless their hearts, they give us a much more reliable history of bleeding than we've ever had before. And then certainly reevaluate her, certainly at the end of that month, make a plan for how you're going to keep this from happening again, and then follow her up at appropriate. As we said, if she's unresponsive or you can't control it otherwise, endometrial sampling Usually what we're going to do there is a fractional curettage, dilatation and curettage, and that will give us a temporary arrest of the bleeding, and it'll give us material to look at histologically. If she has an initial response to the therapy we give, but the problem returns, or if we did a biopsy and it came back normal, or it came back with a pathology that we treated and she continues to bleed, we don't have all the answers. So hysteroscopy and directed biopsy can be very helpful in those situations. And 25% of women who had unexplained bleeding after they even had a D&C can have a cause identified by hysteroscopy. So that oftentimes is, if you've done an office sampling, then the next step is going to move to hysteroscopy. So if she has acute hemorrhage due to anatomical issues or delayed surgical complications, she's going to need surgery. And these are the conditions we talked about. Well, let's move on to chronic heavy menstrual bleeding. Having made a pitch, I hope you heard me, that the safest way to hormonally stop heavy menstrual bleeding in hemodynamically stable women, and here this was defined as hemoglobin greater than 8, was to use that MPA. If you're going to use, I'm going to split back and come back to this for a second. If you're going to use progestin-only methods, particularly at those high doses, that 20 milligrams of medroxyprogesterone acetate 3 times a day, you need to make a note on your prescription or to the pharmacist that that really is the dosage you want to use. They oftentimes think it's an error on your part, and that only adds to the delay, and it makes the patient worry about our acumen, right? So do write on the, if you're writing prescriptions, I used to write a little circle, yes, I really mean 20 milligrams. On the electronic medical records, you just make a note that that is the dose that you want, so that he who is not familiar with that will not be a barrier to her getting this very effective therapy. And it reduces the side effects. Nausea and vomiting are far lower. They're very well accepted. You saw that satisfaction rating for the progestin only, and we have far less need of antiemetics. But importantly, we don't have the increase in DVTs, in venous thromboembolism, that high doses of estrogen given orally will have, particularly in acute bleeding situations. All right, so let's go back to the chronic heavy menstrual bleeding. We've talked about those deviations from her own established bleeding if she has greater than 80 mLs. And as we said here, it's heavy when it's heavy to the woman. And certainly it becomes more common as the numbers of periods is increased. I just thought it would be interesting. What in women, people who are menstruating around the world, the prevalence of anemia is almost 1/3 of women, 29.4% of women in the latest WHO, 500 million women. And high iron deficiency, of course, is the most prevalent nutritional defect on a global scale. And in low and middle income countries, we're finding anemia in almost half of the pregnant women and 40% of the non-pregnant women. And the health impacts are staggering. The fatigue, the headache, cardiac complications. And in pregnancy, you know that these are associated with early pregnancy loss, intrauterine growth restrictions, prematurity, and infections. It's even been associated with problems with pyelonephritis. And some work that we did at Harbor, which is a county hospital, and deals with a lot of homeless women and low-income women. I looked back over 5 years of admissions to our hospital for women who had hemoglobins less than 5 due to heavy menstrual bleeding. Now, I have to tell you, when I asked for the search, I got 122 charts from internal medicine and specialties, high specialties, for women whose whose hemoglobin was clearly not due to bleeding. They had other reasons, the hemopoietic cancers, or they were in renal failure. But in those 122 charts for the admissions, I have to say, not one of them ever captured the woman's menstrual history. They didn't even get last menstrual history. Now, I know that the bleeding is not, if I dealt with her bleeding her menstrual bleeding, I wouldn't cure her cancer. But wouldn't it be wonderful if she could hold on to a couple of those red blood cells? So this is so important to the overall care of women, that you do get a menstrual history, even particularly in the face of anemia, right? What is the contribution there? Or if she comes in with issues around fatigue or anything else, do nail down what her bleeding pattern is. And these, by definition, I had 148 women who were admitted 168 times for a hemoglobin of less than 5. Now, many of those women were readmitted with hemoglobins of 6 or 7, needing transfusion again, but I just kept my wall up there, and it's astonishing. Lowest hemoglobin I had, 1.6. This is chronic menstrual bleeding. You know, you don't want her to stub her toe, but she could die. 1.6 is a hemoglobin, and she was feeling a little tired. This wasn't acute bleeding. 77% of them were in their 40s, and almost half of them had BMIs greater than 35. Now, I want the third note. Please pay attention here. You know that any severe anemia has a high risk of reactive thrombocytosis that goes along with it, and it has to. If she has a defect and she's bleeding from a broken vessel, the platelets have to come in and close that defect very, very carefully. She has to have a rich supply of platelets. In our group, 25% had hemoglobin, had platelet counts in excess of the normal range, and they would have been at risk for VTE if we had added estrogen. And the highest platelet count I had in this population, pay attention, 1.8 million. If she'd had a whiff of estrogen, can you see she could have had a PE? So very importantly, if you're going to use estrogen as a therapy at anything for acute bleeding, particularly acute bleeding in the face of chronic anemia from any source, then please check her platelet count before you administer that agent. And many of them required multiple transfusions. So very important, it can be there. Many of you are familiar with the Palm Coin classification of menstrual abnormalities, where on the left we have physical findings on pelvic exam, on imaging, or on histology that help explain her bleeding. She has polyps, or she has adenomyosis, those endometrial glands and stroma in the muscle of the uterus. She has fibroids, whatever their position is, or she has a pre-malignancy or a malignancy. On the other hand, though, the coin part of it is really functional. Can she clot her blood? Is she on anticoagulants? Does she have ovulatory dysfunctions that are going to keep that, make her have anovulatory bleeding, and also put her at risk for hyperplasia and malignancy later on? Now, you might ask, what are endometrial causes? I mean, didn't we do fibroids and all those other things that are there? These are functional. Usually this has to do with the fact that the woman's prostaglandin balance between vasodilatation and vasoconstriction is off, and she has persistent prolonged bleeding. We sometimes cause heavy bleeding, a copper IUD, or anticonvulsants. People don't think about that, but vitamin K synthesis is interrupted by many of the anti-epileptic medications, and it results in heavier bleeding. And we're not perfect. We may have some that we just don't know how to classify it, at least initially, and so we can give it an N. Just a quick run through. I think you can see on the outside circle, that's the endometrium, and here's a big juicy polyp. And if it were disrupted by sloughing, it could bleed quite excessively. So we know that it can be found in up to 25% of women. They don't all cause problems. Maybe for the endometrial ones, more with infertility. But today, if you run into a little polyp sitting, it's protruding from her cervix, and it's nice and tough, it's not bleeding, and her pap smear is normal, we don't need to remove every polyp. They can be considered variants. But if she has bleeding from a persistent bleeding, then we definitely want to make sure that we're not that we can't just cure it by removing that. So we know that tamoxifen leads to polyps, and many of those undergo malignant transformation. So special cases altogether. So small polyps, less than a centimeter, may spontaneously resolve. Others that cause bleeding need to be removed. I mentioned the adenomyosis, and here you see the perfectly normal endometrial glands and stroma around them, but oops, they're in the wrong place. They're in the muscle, and as she sloughs in her cycle, menstruates through her cervix, she's having that bleeding happening in the muscle itself, and that certainly triggers an intense inflammatory response, which is going to disrupt the hemostatic processes normally needed to stop uterine bleeding. We used to think that this was something that evolved, that as she delivered the baby, we thinned out the wall of the uterus so much that with the delivery of the baby, maybe some of that endometrium invaginated into the muscle wall. So we thought this was a problem of women in their 30s or their 40s. We're finding it in teenagers today. And so we have to put that on the list for women who have heavy menstrual bleeding and young women who have severe dysmenorrhea. We might have called that primary dysmenorrhea because we never thought that they could have had adenomyosis, but we understand today that it can happen and that it's genetic. It is stem cells that got in the wrong place. It didn't need to have labor or a pregnancy to have it. We're getting better at imaging it. The 3D ultrasounds can be helpful, but for those of us who don't have MRIs or ultrasounds in our little clinics, a really good test is that she is pretty normal. She doesn't have pain, doesn't have dyspareunia until just before her period. And if you happen to do a bimanual exam there, you're going to find that her uterus is globular, it's enlarged, and it's tender. And from history, you can glean that just before her period, sex is just very much more uncomfortable. So we have, things that we can identify on exam and history, and then we can really get a better picture of it if we can verify it by imaging. We know that it is related to heavy menstrual bleeding, and a lot of it is, you've got several different etiologies here. The beauty of it is, if you shut down those endometrial glands, you can control this as a problem. So if she's not seeking pregnancy, we have ways of dealing with her problem. And I think we all love Netter's images of all the crazy ways that fibroids can occur. I think what's really fun about knowing this is each one of those fibroids is monoclonal. Every cell in there is identical to every other cell, but they can have wild behavior, and unfortunately, they actually are very, very common. Most common uterine neoplasm, 40 to 80% of women will develop at least one of them. For some of them, it becomes very symptomatic. We can see that 25 to 50% of women with fibroids are symptomatic, but oftentimes the diagnosis is delayed, and it's kind of strange that it would. But certainly the adverse impacts are really quite impressive. In the United States, the estimates range from just caring for these women and the impact it has on their health and quality of life. Estimates range from 6 to 34 billion. I know a billion doesn't seem like as much as it did before, but that's a huge number and a substantial number of increases in visits to the ED. We are now classifying the leiomyoma by the position within the uterus. And this is one of the things that FIGO liked, is that we could meld into their classification. They can grow very, very large. The largest one I've ever removed was 47 pounds and enormous. They can outgrow their blood supply and degenerate or necrose. They'll generally shrink without estrogen, but you can't rely on that. So 73% of women who had self-reported fibroids said that they had heavy menstrual bleeding. And we can say 60% of women who knew that they had fibroids internationally said that they had heavy bleeding, and more than a third had prolonged bleeding. So anemia and fatigue, certainly very, very prevalent in this, and it warrants our attention. And I think this is a very telling conclusion. Uterine fibroids are associated with disabilities similar to that of other chronic diseases, lower vitality and social function than women with breast cancer. Isn't that amazing? And we see that fibroids account for 45% of all hysterectomies in the United States, and the lifetime risk of getting a hysterectomy if you have fibroids is 45%. All right, well, let's move on to deciding how to help her with heavy menstrual bleeding. When does she want to get pregnant? Does she want to hold on to her uterus? If she has fibroids, where are they? How big are they? What are the symptoms? What are the impacts? And what's the patient preference, and what's the cost effectiveness? So with fibroids, we can start with the usual things, the nonsteroidal anti-inflammatories. We can get antifibrolytics. We can usually control with the endometrium with hormonal contraceptives. We can give progestin only. For these short-term GnRH agonists, and what I really want to point out is the new element there, and that's GnRH antagonists that now come with add-back, estrogen and progestin add-back. They're adding a whole new modality for us. And then the new things, certainly things that are used in Europe, the ulipristal acetate, and short-term courses where you shut off the estrogen by using aromatase inhibitors. So you've got all kinds of extremes that are there. And if you're going to use hormonal contraceptives, please don't make her bleed cyclically. There's no reason to give her placebos. Try to do extended cycle. So in heavy menstrual bleeding, the lack of thick and extensive endometrial tissue, this is due to the other issues, the endometrial hyperplasia and malignancy. There are screening tools for bleeding disorders that you can ask. I love this. They say there are only 8 questions, but look how many A's and B's they squeezed in there. So if you suspect she has heavy menstrual bleeding, tools like this can be helpful to us. What are the disorders? Now we're into the functional ones, and that would be platelet aggregation defects are usually underestimated. Folks will say, well, let's rule out von Willebrand's. If she's got bleeding gums or had heavy blood losses with other things or easy bruising, but really oftentimes the heavy bleeding is the tip-off. And it's genetic, it's if it's von Willebrand's, it's her whole life, but platelet function defects actually can emerge in the 20s and 30s. So you think maybe that's the fibroid that's doing it. But please pay attention to the fact that it could be a coagulopathy. If we look at this study, and there have been several of these, 115 women with physician-diagnosed heavy menstrual bleeding, almost half had a hemostatic abnormality. And what was the most common one? Platelet aggregation. It wasn't von Willebrand's. It varies by population, but we can certainly see very common abnormality in particularly African American. And we can see this in study after study, how very important platelet disorders were. Now, you and I can control her heavy bleeding without knowing that she's got a perfectly normal platelet count, but she can't clot her blood. They just don't work. And we can make that all right from her heavy bleeding. I can put her on pills. You can give her Depo. We can make that problem go away. But what if she's in an automobile accident? Wouldn't it be nice that the paramedics could know I can't clot my blood? Or if she gets to the hospital and they know she has an underlying bleeding disorder. So identifying those women for health reasons elsewhere is so very important. We talked about ovulatory dysfunctions causing anovulatory bleeding due to asynchronous bleeding, also due to prostaglandin disorders. And these can appear anywhere in those areas. But we talked about the abnormalities that occur with endometrial causes. And oftentimes it gets down to this last point where the prostaglandin receptor concentrations are much bigger for PGE than they are for F2 alpha. So looking at women, normal controls in ovulatory women and anovulatory, I think it gives us insight, but we've discussed this, so I'm going to skip over this. Iatrogenic causes we talked about, and we highlighted the anticonvulsives as being important. Now we want to move quickly as we get to the end here. Chronic heavy menstrual bleeding. We want to know, first off, is the heavy bleeding due to a treatable organic cause? If I give her thyroxine, is that going to make it better? Is her bleeding ovulatory or anovulatory? And very important, what is the burden of symptoms and what are her expectations? I had a patient who came in and thought that the birth control pills that she had taken after she'd had a heavy menstrual bleeding episode in her early 40s had failed her because her bleeding was back. She didn't understand that she had to keep taking the pills. It wasn't curing her, it was controlling the symptom. So when we're giving her therapies, we need to set her expectations about what the goal is with it. We want to get a menstrual history, we want to get a medication history, and then sexual history, particularly as we said, potential for pregnancy, and how much does she need protection from sexually transmitted diseases. On physical exam, we're going to look for all things that could be hormonal issues and certainly signs of anemia or hormonal imbalances. This was a recommended list of all the laboratory tests you could do, and I'm going to let you decide how many of these you need to do given in a different case. Imaging studies can be helpful, and I do want to suggest that if you think there's something going on inside her uterus and you want to image, this is really a step forward. That during a transvaginal ultrasound, they can put a pediatric feeding tube in and infuse normal saline so you can identify the polyps or you can see the fibroid. It's not just a squished down, thickened endometrium. You get a lot more information. So if you have access to this, it's a wonderful tool altogether. We have to use our biopsies correctly and for the right women. If she's under 45 and she's had unopposed estrogen stimulation, we probably do want to get a biopsy on her. And if she's had failed medical management and she persistently has abnormal bleeding, we want to do it. But we recognize that it is a blind procedure, and we know that hyperplasia and carcinoma start as focal lesions. So we really want to find out if our initial test doesn't give us definitive answers. That's where we come back, as we said, to the hysteroscopy. I did want to show you some other work that we've done looking at women who had endometrial aspirations. And you can see we looked at 1,600 cases, and we only found that 4.6% of them had cancer. Another two, I'm sorry, that's 0.46. And we had an additional hyperplasia with atypia. But where were those? Those were, by and large, women who had diabetes and obesity in the younger age, and in the older age women, of course, any postmenopausal bleeding you're going to work up. But it was much more common, particularly in our diabetic, although the BMIs didn't have as much of an influence. All right, the things that we want to look at for therapies: how old is she? What are the severities? Does she have other pelvic pathology? And to realize that most therapies are going to be off-label. We now have 4 things that are approved by the FDA for the treatment of abnormal bleeding. One is cyclic MPA, not so good for heavy bleeding, but unless it's given continuously. But then we have the hormonal IUDs, we have tranexamic acid, antifibrinolytic, and we actually have one birth control pill that is approved for the treatment of heavy menstrual bleeding, and it works as well as the hormonal IUD does. But let's just run through theirs. We can normalize the prostaglandins, high-dose NSAIDs. We can decrease fibrinolysis by giving antifibrinolytics. We can coordinate the endometrial sloughing, suppressing it a little bit, combine hormonal contraceptives. So if she has anovulatory heavy bleeding, well, then make her bleed every month or so. And you can do that by cycling with progestin or cycling with hormonal contraceptives. But better yet, suppress the endometrium. Give extended cycles. You can use pills, you can use vaginal rings that have estrogen and progestin, or you can use, as we say, the levonorgestrel IUS. We can see that the NSAIDs will reduce menstrual blood loss by about 20% in anovulatory bleeding, and they can be used in conjunction with hormonal therapies. And these are the typical ones we use. It is very important if you're going to be using things like ibuprofen, 800 3 times a day, every 8 hours for up to 5 days. If she stops bleeding earlier than that, you can back off. If you let her go longer, the antiplatelet activity overwhelms the prostaglandin activity, and she'll actually bleed more. So you need to get the dosing and the timing right. We talked about tranexamic acid may increase the risk of thrombosis particularly if she's using estrogen. We use the one FDA approved, but really all pills are assumed to be able to reduce menstrual bleeding. But as I put in the pitch already, extended cycle use of everything but the patch is very effective. So we want to suppress menstruation, try to get women to understand that when you're using hormonal contraception, menstrual suppression is healthy. There's actually no medical benefit to inducing periodic scheduled bleeding if you can get amenorrhea. But there are substantial health risks and suffering when scheduled bleeding is induced. So if we can make women feel comfortable in skipping some periods and just avoiding the heavy bleeding altogether. So we prevent endometrial thickening by using any of these progestin-only methods, and I know many of you use DMPA. If she has bleeding on DMPA, ask when it is. If it's toward the end of the period, right around week 12, you can shorten the interval and get jump-started to amenorrhea, and that can be even more healthy for her. And we can see the trend toward amenorrhea, 0 days of bleeding, grows dramatically over time with this. The bleeding with the hormonal IUD, very effective, 70 to 90% reduction in blood loss. And in the comparative study that we did, very, very rapid onset of normal blood loss. And compared to ablation, which is a surgical procedure that you can only do if she absolutely doesn't want any more children, this IUD office placement is equivalent. No difference in patient satisfaction or quality of life. I did want to talk a little bit more about those oral GnRH antagonists for fibroid-induced heavy menstrual bleeding. We now have 2 products that are available to us that can be used for up to 3 years and are amazingly effective. Amenorrhea rates greater than 50%, and the impact on bone is small because you're giving estrogen add back. If you give estrogen low dose, you've also got to give progestin to protect. The last one is in clinical trials as doing very, very nicely altogether. Surgical therapies, if it's leiomyoma, we can take out the fibroid or we can embolize it. We can ablate the endometrium. We scarify the endometrium, and we can, of course, do hysterectomy as the definitive. So I think we can realize that menstruation isn't physiologically necessary in women without cyclic endometrial proliferation. What am I saying there? If she's not cycling normally, if we're controlling her hormonally, she doesn't need to bleed, right? And women who are burdened by menstrual cycles, long-acting hormonal suppression of ovulation is feasible and it is safe. And hormonal therapies are effective for regulating, reducing, eliminating, and even timing menstrual cycles. Women who want to go on religious pilgrimages, we can make sure that they're not bleeding so that they can participate in all aspects of it. So from this, I hope we've learned menstrual bleeding disorders are common, that up to 1 in 5 women will experience debilitating symptoms of heavy bleeding at some point during their reproductive years, that heavy menstrual bleeding can be a sign of systemic disorder, a coagulopathy, or other diseases of the reproductive system, that most of the causes, fortunately, are going to be benign, and the symptoms can be effectively managed with hormonal therapy. And the last little thing, I know it takes a lot to persuade women, but menstrual suppression is healthy, and we need to advocate for quality of life, and this is a very important tool. I thank you very much for your attention and your patience in getting this a little bit late. But I'm happy to take questions. If you want to send any into the group, I'll be happy to email you answers. Talk to you later. Bye-bye.
Great. Thank you for that, Dr. Nelson. Really appreciate it, and a lot of information in a short period of time. So to facilitate questions, I'll have one myself, and anyone in the audience, please raise your hand if you have
I guess
any. But we're going to be moving, Global Offsite Care and Global Ground Rounds going to be moving to a new platform starting soon, and we'll display that next month. That allows us to not only share recordings of excellent presentations like this, but facilitate interaction. It's called Figure One. We've been around for about 10 years, figure1.com, and we'll send all of you a link to that. And if, with your permission, Dr. Nelson, we'd like to facilitate kind of a 24/7, 365 environment for collaboration, not only for Q&A on presentations like this, but actual cases. So we know that quite a number of our partners have questions about ongoing issues with specific patients, and this platform readily de-identifies those patients, so we protect confidentiality and privacy, but at the same time facilitates helping us meet our mission to decrease suffering and collaborate on behalf of individuals in remote environments that could really benefit from that. So if there aren't any questions from the audience, I'd like to pose one specific to handheld ultrasound, and one of our attendees today has been so helpful in bringing handheld ultrasound to the field for some of our partners. And with that, is there a role for handheld ultrasound in the workup of women suffering from this condition that could at least get us to fairly rapidly to a place of differentiating those women that may be suffering from a lesion, fibroids, malignancies, et cetera, using handheld ultrasound? And I know the limitation there is that it's not transvaginal in nature. And is there anything from your experience that would allow us the opportunity to say, hey, this is an application, a clinical setting that might benefit our women who are suffering out there?
I think that's a great idea. I mean, if it's transportable and we can get something is always better than nothing. Okay, and we don't want excellent to be the enemy of good, right? So if we can find an issue, the issue is to be able to measure the thickness of the endometrium through the abdominal. If it is exam, ultrasound imaging, if you find an egregious lesion, if it's super thick, then that can be helpful. That can be useful, and it probably is worth a peek to take a look. My only concern is, if I may, that the finding of a fibroid, right? You do the ultrasound, you find a fibroid. It might be helpful if you can distinguish that it's subserosal and is not going to have anything to do with her bleeding, right? It's going to be the intramural or the ones that are inside the user, submucosal, that are involved in heavy bleeding. But be careful in attributing the bleeding problem to an isolated fibroid. We have to keep our minds open. One small fibroid is not going to be causing hemorrhage, right? We have to recognize that. But it would be important to inventory the woman's all of her problems. And if you have a lesion, I don't know why you couldn't feel it on pelvic exam, but perhaps we're in a situation where the patient is declining an exam, right? And that maybe something transabdominal might be acceptable. Oftentimes in countries where we have to be careful with entering the vagina, we can actually do a rectal exam, abdominal and rectal finger, and again, using the tools that you have handy with you, you can help define disease states. But that's actually more sensitive in many areas. Don't forget that you can access the pelvis very nicely through a rectal exam. But a trans-abdominal ultrasound may be helpful in that sort of situation too. You take a peek at her ovaries and see. I wouldn't get all excited about counting follicles or anything like that. You're really looking for large disease that could be contributing. Yeah.
Mhm. Okay. Yeah,
Actually,
thank you. Appreciate that.
let me just do something. Every one of the things I did today was AUB dash one thing. Yes, that it would be she either had polyps or she had fibroids or she had a coagulopathy. We know in nature it's going to be abnormal uterine bleeding dash, give you a whole list of things that could be going on. Yes. And it's perfectly reasonable that she could have a leiomyoma, but that may not be causing her bleeding. It may be something else that's there. But get the complete picture of what she has so that you can to work forward with that. So, yes.
Great. Thank you. And I think we have time for one more question from one of our supporters, Mary Graves. Thank you so much for your ongoing support in that regard, as particularly with handheld ultrasounds in the field. So, Mary, you had a question?
Yeah, well, I'm really sorry Dr. Smith isn't here today because I was with him last month and we were able to access this by his phone. And as you know, his house burned down on a small remote area where there is no insurance. And so there's a GoFundMe page. And so I know that Michael Cook let all of you know, but if you can contact me and I'll forward it to you, but we're all just helping him rebuild. And he's still practicing medicine every day, just like any of you other wonderful committed doctors. But I did have one question, Anita, because Dr. Nelson, I'm sorry.
It's fine. We're here together. That's
I
right.
did have one question because I work with the handheld ultrasound with Dr. Smith and I'm familiar with it. I wanted to make sure I got clear. You can use it to determine fibroids, right? You may not be able to tell what kind, but you can. That is one listed use of the handheld. You can find fibroids.
Yeah. You may not define.
Yes.
You may not be able to see adenomyosis the way you might with the others, but you can see a disruption, right?
Yeah.
Right. You can. Yes. You may not be able to say, for sure that's a fibroid. And if it's protruding into the endometrial cavity, there's something there. I don't know. Is it a big old polyp like my tongue is sticking out, or is it a squeezing? But I can see there's something distorting the endometrial cavity. I get a straight line on the endometrial cavity, and it's kind of pooched over to the side, right? I think that.
Well, this was a great session, Dr. Nelson. Thank you so much. Even us lay people could understand.
Well, thank you so much for your work, and thank you for the question.
Sure.
The more tools we have, the better it is for women.
And before we close, I'd like to point out in our chat, we have a so kind entry specifically thanking you, Dr. Nelson. It states, "This has been such an excellent training. Thank you for sharing this valuable session with us. I greatly appreciate this and your work at large for reproductive justice." Thank you.
Thank you.
So,
all right, I feel good. Pat me behind the ears. That's lovely. Thank you all for all the work you do.
appreciate your work and for the presentation. And with that, we'll hand it back to Aisha to close.
All right, thank you so much, Dr. Nelson, for your insightful presentation. This recording will be uploaded to our YouTube channel in a couple of days. And as a last reminder, please go through the links that I provided down in the chat. You can register for Figure 1 through those links. If you're interested in presenting for the next Global Grand Rounds, please send me an email. Our next Grand Rounds is on April 10th. And as always, we appreciate your participation and continued interest in Global Grand Rounds. Have a great rest of your day.
Bye-bye.
Thank you.
Bye, everyone.